Hello everyone, this is Chadi Alraies from SIF 2024. I'm really privileged to be with Dr. Stephen Yakubov to talk about new technology. It's presented at SIF as well for tricuspid mitral valve disease. Dr. Yakubov, thanks for being with us.
Thank you, Chadi.
So we presented here a few live cases as well as presentation. The mitral valve kind of evolving quickly, and there's new options in the horizon and currently. Can you walk us through a few of them?
Absolutely. So the landscape of what we do currently are often involving sapien valves from the surgical position into the mitral valve. So the three categories that we do are transcatheter mitral valve, transeptal, and surgical valves that have degenerated. The others are transcatheter sapien valves in mitral valve and ring. And then finally, MAC cases, so severe mitral annular calcification, specifically 360 degrees of MAC are the ones that we've been working on. And I think the technology has evolved. S4 has helped us, and the learning curve is getting better and better and better. So the results are quite amazing.
Yeah, and there's multiple studies and registries about these three categories as you mentioned, and show favorable outcome in these patients.
Correct.
But and now we have newer valve that you can do replacement of the valve.
Correct.
Yeah.
So the next evolution will be our transcatheter mitral valve replacements, and there's numerous studies out there right now of Evoke in the mitral position, M3 in the mitral position, and then ongoing studies such as Apollo in the mitral position. The good news about some of these valves, such as Apollo, is there's a MAC arm of the valve, so it doesn't have to be purely functional valves. We're testing them in patients with mitral annular calcification with excellent results.
Yeah, and these valves are delivered transeptally as well?
Transeptally. Many of them are 36 or 38 French, but it doesn't seem to be a problem with femoral venous access. Most of them are still done percutaneously, and they're closed either with perclosed sutures or figure of 8. The other issue you think about is what happens to the septum. And the septum.
And LVOT and obstruction.
Correct. And so the septal issue, some of the septum are closed afterwards, depending upon how much shunting is occurring. The LVOT issue is one of the main reasons for patients not to get enrolled, and so we have a lot of LVOT mitigation issues like alcohol septal ablation, coil embolization of the septum. Now some patients are getting sesame, and then of course we don't allow Lampoon in the Apollo trial yet, but Lampoon is becoming much more common.
Right, but we're allowing to opening the valve properly.
Yeah. So it's been a great, there are many tools that are being developed to allow us to approach more and more of these valves. I think the imaging ahead of time is really essential. CT imaging to predict what the neo-LVOT will be is essential. The imaging has gotten very sophisticated, and the other thing is the imaging during the case is so important. Our non-invasive imagers have become outstanding. They're getting better all the time, and they are truly the key to the procedure.
Right. So we're going back to the new LVOT, which is a new LVOT that developed after you deploy the valve. So there is, with the new technology now, the CT can replicate what is the LVOT gradient will be?
Yes. So we typically model the neo-LVOT with a virtual valve implantation on 3 Mencio software. And there is even more sophisticated software such as FIOPS and DASI simulation, which will help us predict what that neo-LVOT will be. So we don't do the patients that will have problems, but we'll do the ones that could benefit.
And the accuracy in clinical practice is very accurate. The replication of that neo-LVOT measurement is very accurate from CT virtual to real case.
Yes.
Okay.
Yeah.
Last point is about management after the valve in terms of risk for pacemaker. I know we are away from the Hespropyngy and antiplatelets.
Yeah. So pacemakers don't seem to be much of an issue in the mitral space for us. However, the valve replacement technology, we are still putting on anticoagulation, full anticoagulation with warfarin. We don't know if the direct oral anticoagulants will be as good as warfarin. We're a little unsure about when we should test that, but warfarin is still our mainstay, and we give that anywhere from 3 to 6 months following valve implantation.
And then you stop it?
That is a consideration of stopping it. Yep.
But based on the trials and stuff, this is part of the requirement, 3 to 6 months.
Yes, absolutely.
All right, well, this is very nice overview, and I think the future is coming. The future is here, I should say. We're just waiting for these trials to come up and with new solutions. Again, thanks Dr. Yakubov for your time. Watch these videos and others on SIF YouTube channel. This is Chadi Alraies from SIF. This is the 20th anniversary. Thank you so much.
Thank you.